we'll get started. Again, hi, I'm Dr. Palapu. I'm with the Department of Medicine, and it's my pleasure to welcome you to the Own Your Health community forums. And it's your opportunity to join medical experts at Providence Healthcare, share with them about lots of different topics that they do teaching, research, and clinical care in. And each month we feature an expert, and we usually have this on the third Wednesday of the month, and it's usually at the New Lecture Providence Healthcare Theater. And it starts at about 7. It'll end probably around 8:30. So the format for tonight is we're very honored to have two esteemed colleagues of mine, Dr. Nadia Khan and Dr. Jake Onrot, who have an expertise in the diagnosis and management of hypertension, which is a very common disorder that is increasingly affecting people. So I'm going to give you a little bit of information about each of them, and then they're going to sort of tag team and do a presentation for you, and then you'll have an opportunity to ask questions. And the format for the question and answer period is that we have these sheets of papers, and we ask you to write out your question, and I would request that you write it out as legibly as possible and sort of one question at a time. And what I will do is I will ask the expert, and they will give a response. And then afterwards, you can have a few minutes to mingle. Apparently, all the fruit is gone, so I'm glad everyone's well fed. So first, I'd like to introduce Dr. Nadia Khan, and she obtained her medical degree in her core internal medicine training at the University of Alberta, and she completed a general internal medicine fellowship at the University of Calgary, as well as a master's degree in community health sciences epidemiology program. In 2005, we were fortunate enough to have her relocate at University of British Columbia as a clinical instructor, and she did postdoctoral research here under Dr. Adira Levin, who is someone who gave our talk on chronic kidney disease. She was promoted to assistant professor at UBC, and she just became promoted to associate professor in 2010. She's been supported by Michael Smith Foundation, as well as the Alberta Heritage Foundation and the Canadian Institutes of Health Research for her salary support. And currently she's a new investigator with CIHR and also receives support from the Genesis Scholar Award and the St. Paul's Hospital Physician Scholar Program. She's interested in differences in the course of illness depending on gender and ethnicity, particularly of patients who have diabetes and other cardiovascular diseases. So obviously, hypertension fits in with that. Dr. Onrot completed his medical degree at University of Toronto in 1975 and did his residency training there as well. He pursued a 2-year research fellowship in hypertension and clinical pharmacology at Vanderbilt University in Nashville, Tennessee. And then he became a faculty member at University of British Columbia in 1985. And he's currently a clinical professor of medicine as of 2007. And he's considered one of the best teachers at St. Paul's Hospital and UBC. And he's been recognized with numerous teaching awards, including Best Teacher, Howard B. Stein Master Teacher Award, and as well as the UBC Master Teacher Award. And he has probably one of the largest blood pressure clinics in all of British Columbia, I would say, and he has it here at St. Paul's Hospital. So I'm going to stop talking and turn the podium over to them, and I believe there may also be a demonstration where you, the audience, has to point out what may be going wrong.
Thanks very much, Anita. So I'm also a member of the Canadian Hypertension Guidelines. The program is called Canadian Hypertension Education Project. And as a part of what the nickname is CHEP. And as a part of CHEP, we have publicly available slide kits and demonstrations, videos on how to take blood pressure. And it's on this website that I really encourage you to go to. It's called hypertension.ca. And you can get patient information, diet information, all sorts of information on hypertension, how to manage your blood pressure and diet. And these slides are also apart from the CHEP guidelines. So what we're going to talk about in the next hour or 40 minutes or so is really what is high blood pressure, and then why should I care about my blood pressure, what causes it, how do I know if I even have high blood pressure, can I measure my own blood pressure, how do I lower my blood pressure, and what about medications? So we're going to start with actually what is blood pressure, and blood pressure is exactly that. It's pressure in the blood. So think of our blood vessels like a rubber hose. We want to keep the hose as rubbery as possible, and that way it can stretch when we get blood there, and it relaxes as well when the blood pumps through the rest of the body. So blood pressure is actually that pressure of blood in those blood vessels. And that blood in those blood vessels needs pressure because that's the only way the blood is going to get from the heart to the rest of the body where we need it. So it needs a certain amount of pressure to push that blood through that hose to the rest of the body. The thing about blood pressure is we really don't feel it. So we can't feel that blood moving through our body, and that's sort of the way the body wants it. So what is hypertension? So hypertension is what we say is abnormally high blood pressure. And it can be due to different things, which I'll go into a little bit later, but it's a condition where the blood pressure is generally always high. So it's not the case where you're yelling at a guy in traffic and somebody takes your blood pressure and it's high in that hour or that half hour. That's not hypertension. Hypertension is the kind of blood pressure problem where it's high pretty much all the time. And we have in the scientific community said that high blood pressure is blood pressure greater than 140/90. And I think probably many of you have heard those numbers before. So why should I care about having high blood pressure? So if we look at all of sort of the problems that cause the major diseases like heart attack, stroke, all of those major problems, we think about smoking as a bad problem, drinking too much alcohol, having high cholesterol, high blood fats, being overweight. Those are all problems that we all know contribute to disease. But when the World Health Organization looked at what is the one problem that's the biggest problem for the world, it was hypertension. So hypertension, as I've mentioned earlier, can cause a stroke. And a stroke is that condition, often confused with a heart attack, but a stroke is when there's a problem in the brain and you don't get blood supply to the brain, so you lose function in either your arm, your leg, both, can't speak, lose part of your vision. Those are the common symptoms of a stroke. Heart attack, most people get chest pain, shortness of breath. Part of their heart dies and gets scarred and doesn't pump properly. People can die from heart attacks, especially if they're large heart attacks. Kidney failures, so kidneys are the organs that excrete all of our toxins, so they can slowly cause kidney damage over years of having high blood pressure. It can cause impotence too, so a lot of people didn't know that, but impotence is one of the most common causes of impotence, is a problem with the blood vessels, and hypertension is one of the most common causes of blood vessel problem. It can cause dementia. This is something we've learned about in the last 5 or 7 years, that a significant amount of dementia that we thought was due to Alzheimer's is actually more due to hypertension. Eye damage, blindness, for example, and also early death. So the good news about hypertension is that if you control your blood pressure, you can reverse a lot of those risks. So if we look at things like I mentioned to you, heart attack or heart failure, that's when your heart doesn't pump properly, treating your high blood pressure can cut your risk of having heart failure in half. So it's a huge benefit from treating and controlling your blood pressure. It can even cut the risk of death and dying. So treating hypertension is the good thing about hypertension is something you can control, and by controlling it, you can cut your risk of those major problems that we don't want to have. This is just some pictures so you can see what I'm talking about. This is somebody who died, obviously. This is a picture of somebody who had a stroke, and you can see where the red arrow is. That's the brain where there was a blockage in the artery. So as I mentioned before, blood vessels are important to deliver the blood. If we don't have blood to a certain part of the body, that part of the body dies. So this is a picture of the brain where part of the brain has died, and that causes a stroke. Another thing that hypertension can cause is what's called a bleeding stroke or hemorrhagic stroke. I'm not sure if You've heard of this before, but what happens is a blood vessel can burst because of the pressure can be too high, and that causes this kind of a stroke, which has the same effect in that it causes brain damage. This is a picture, you know when the doctor looks in your eye with that wand? This is what the doctor is looking at. On the left, you can see a normal eye with the nice blood vessels and the nice pink background, and the light-colored spot is where all the eye nerves come out of. In patients that have hypertension, after many years, you can see that the eye becomes damaged, and in that patient, they may not even have blurry vision at this stage, so they may not even notice it. But what happens is you can see the blood vessels become thin and wiry, and they also can leave fatty spots on the back of the eye and can cause more of those bleeding into the back of the eye, and that can cause vision problems. So let me just ask the audience a question. How many Canadians have hypertension? Let me just hear some numbers. What are people thinking? 80%, okay. 1 out of 3. 1 out of 5, so really great guesses. So 1 in 4 Canadians have hypertension. If we were looking at elderly people, the numbers would be closer to 50%. So some of you mentioned really high numbers, but that's more in elderly people. This is all of 18-year-olds and above. So 1 in 4 Canadians have hypertension. So it's a huge problem in Canada. What are the causes of hypertension? A lot of it is unknown. There's been many, many years spent on trying to figure out what is the cause of hypertension. In about 1 out of 20 patients, we can say your high blood pressure is due to kidney disease or something like that. But by and large, we don't know what is the major cause of hypertension. We've done studies in the past, though, that have shown that genetics or family history plays some role, but it's not the whole answer. Probably the largest contributor for hypertension is actually lifestyle. And what do I mean by lifestyle? How does lifestyle cause hypertension? Things like being a couch potato, that causes hypertension. Not a good diet, that can cause hypertension. Too much salt, especially in Canada, where everything that's in a package is overloaded with salt and sugar, that can cause hypertension. And of course, being overweight can cause hypertension. Also, things that some people don't know can cause hypertension: excess alcohol intake, well, clearly known to cause hypertension. Smoking can also raise your blood pressure. As well, in some patients, stress can cause hypertension. So how do you measure blood pressure? And Dr. Onrot and I are just going to show you sort of typical, I don't know, first of all, let me just ask you, how many people measure their own blood pressure at home? Okay, so lots of you. So this is going to be really relevant. So we're going to show you an example using this kind of blood pressure machine. It's obviously not the one you're using at home. You're probably using one of those automated cuffs, but a lot of what we're going to show you is relevant to this. So I'm going to pretend to be the patient, and Dr. Onrot's going to be pretending to be the... I'm going to pretend to be a doctor. Okay, so I'm going to come into my appointment, and this is a very typical scenario for the patients that I see coming in. Okay. Oh, hi, Dr. Onrot. Oh, I couldn't get parking. It was, oh, God, what a nightmare.
That's terrible.
Yeah, I couldn't, it was just terrible.
You know what, I'm late for my next patient, so I just gotta here, have a cup of coffee while I take your blood pressure.
That's exactly what I need, a cup of coffee, because I had 2 cups this morning, and I usually need a couple more to get me through the day.
Okay.
God, I tell you, what a rough day I had.
Well, let's just get this done. Why don't you give me an arm?
Okay.
Okay, thank you very much.
Okay, great. God, is that a new machine?
Brand new.
Oh, great.
Oh, yeah, never been used before. As a matter of fact, it's the first time I've ever done this.
Okay, not bad. Okay. Oh, I also wanted to make sure to tell you I get this pain in my knee when I go down the stairs.
Yeah.
Yeah, and my knee sometimes goes like this for no reason.
Yeah, and how about that kid of yours that's
Oh my
been
God,
trouble?
don't get me started on my kids. That is really tight. Oh my God.
Well, try not to look at it.
Okay. Is my blood pressure high?
Well, try not to look at it, okay? It's like 150 over 80. Yeah.
Oh my God, I'm going to kill my kids when I get home. It's them, they're doing it. Okay, so what we want to talk about is what went wrong. How is this not the way you take blood pressure? So who can spot the errors, the many errors?
You need to put the cuff on without any clothing.
Right, perfect.
Caffeine and you should relax before.
Exactly,
At least.
perfect.
You should take
No talking. No talking is a huge issue. 3 readings, 2 or 3 readings.
a few minutes in between, right?
Yes, excellent.
Can you take pressure over your sweater?
No. And not even like the other thing I get a lot of is this rolled up shirt tight around. You can't do that either. It has to be really either loose clothing or a t-shirt to take your blood pressure.
Any other
Should
things?
your arm be relaxed on the
Good.
table?
The arm should
Perfect.
you shouldn't be holding your arm up because that takes physical exertion. It's going to raise your blood pressure as well, and it should be at heart level. So if I measured your blood pressure up here or down here, it would probably be different, wouldn't it? So in both of those, her arm was improperly positioned.
Yes.
And her legs crossed?
Exactly. That's exactly right. So legs crossing will raise your blood pressure as well. Anything else? That's excellent.
I can't remember. What else do we do wrong?
Drinking coffee. Drinking coffee.
Earlier for your appointment.
Yes, I should have left earlier for my appointment. Great.
You really shouldn't be chatting, and certainly the doctor. It's up to the doctor not to stress the patient and remind them about their stressful home lifestyle, etc.
Now, if you're wearing a white jacket, I hear that raises blood pressure.
Do you want to answer?
That's an excellent issue, and that this is a whole issue. You've probably heard of it: office-induced or white coat hypertension or white coat blood pressure. So there are some people, not everybody, and probably not a huge proportion of people with hypertension, have this thing where they come into the office and their blood pressure is just raised from that. And there are clues that people have white coat hypertension. So
Lots of doctors don't bother wearing white jackets.
it's not even the white coat. It's actually the office, being in the doctor's office, that's associated with it. And I think you were going to talk about that at the end.
And just, I wasn't going to talk about this, but since you mentioned it, if you go into a doctor's office and you get an automated recorder, the pressure recorder will be lower than the pressure recorded by a nurse, which will be lower than the pressure recorded by a doctor. So that's important, and that's why for many, many years I had my nurse do all the blood pressures so that they'd be lower.
More accurate.
And more accurate. And I'll talk more about that later, but when I first started in practice, I had one of the first automated recorders that did a little printout, and I would leave people in a room, hook them up, and go away and check their blood pressure every minute. And it was amazing how much it would fall in the first 5 minutes with them left alone. So we basically decided from the literature that 5 minutes, your doctor should leave you alone for 5 minutes before they measure your pressure and not talk to you when they're measuring your pressure. So those are a few important.
And if you're in this kind of a setup, which often doctors' offices are like this, or even your home, you just simply rest your arm on the table next to you and make sure that you're in a seated position with a back to it. So not like this, but a back to it, rested arm at heart level. Okay, so what do the numbers mean? People often talk about the top number and the lower number. So the top number is when the heart actually beats. So it's that volume of blood that goes to the rubber hose blood vessel. If you could take a blood pressure cuff and wrap it around that blood vessel, that's the pressure of the blood going through. The lower number is really when the heart relaxes. And I mentioned to you that the blood vessels, we want them to be a rubber tube, just like the heart, we want it to expand and relax, expand and relax. So the lower number is the relaxing number. Okay, so typically the first number is the systolic blood pressure, that's the heart beating or blood volume number, and the bottom number is diastolic number. So in this talk, we're going to talk about systolic pressure and diastolic blood pressure. So you all have an idea of what those mean. Okay, so now we're going to move on to how do you know that you have hypertension? So the truth of the matter is many people have hypertension, but they don't know it. So I'm going to ask if people feel free or feel comfortable to say, how many of you have hypertension? Okay, so many of you have hypertension. The only way to find out really is to get your blood pressure checked. And unfortunately, there are no symptoms like headache and things like that to warn you that your blood pressure is high enough. We just have to simply, every time we go to the doctor's office, get a blood pressure check. So how can I check to see if I have hypertension? So who can measure my blood pressure? And of course, you know the family doctor can, and you know the nurse can, but the critical piece is you can measure your own blood pressure. And that's a critical piece in determining whether or not they have hypertension or not. So if your blood pressure is in the good range, 130/85, you should get it checked every other year. The higher your blood pressure is, the more frequently you should get it checked. If you have hypertension, every time you see a doctor, you should get your blood pressure checked. And can you measure your own blood pressure? And it seems like many of you are actually checking your own blood pressure at home, which is excellent. You can get these home blood pressure monitors in the local pharmacies, and you see this heart with a check mark. That's sort of the standard approved blood pressure monitors. Okay, and these are the ones that are endorsed, that have good calibration, so they make sure that the number you get is a correct number. And again, make sure when you buy your blood pressure cuff that you get the right cuff size for your arm, big, medium, and small. And again, this is the slide I showed you earlier on why it's important to treat high blood pressure, again, to reduce risk of heart failure, stroke, heart attack, and death. So who should get treated for hypertension, and do I need medications to control my blood pressure? So we're going to go through this case. So this is Mary. She's 68 years old. She's a retired accountant, and she comes into the office, and her blood pressure is 154/90. And I've told you that the diagnosis of hypertension is 140/90. So her blood pressure is 154/90. She's pretty much healthy, except she has angina, which means that she gets chest pain or heart pains every time she walks 5 blocks. And she's seeing her heart specialist about that, and that's stable. So the question is, should she be treated for her hypertension? And how many of you think that she should be treated for her hypertension? Okay, so pretty much everybody does. Okay, great. So the first thing is when a physician sees a patient with high blood pressure, several things run through the doc's mind. First, make sure there isn't a reversible cause of high blood pressure. Just like the demo we did here, somebody rushing in, somebody had a bad day, somebody's sick. What was the cause of that high blood pressure? Can I find a reversible cause? You know, I see a lot of patients that have strokes, and unfortunately, stroke is caused by high blood pressure. And I've seen patients that have high blood pressure simply because they take cough and cold medications every day, and that's their cause of hypertension. So as a doctor, you will look for what are the causes, reversible causes, for causing the high blood pressure. Second, what I think was your point, make sure that blood pressure elevation is consistently high. We're not interested in one-off. So if your blood pressure is good, but one day it was high, we're not worried about that. We're really looking for an average over several days. The reason why we do it 3 times, take your blood pressure on 3 different visits, is because there is a natural fluctuation in blood pressure. So the more times we read your blood pressure, the more accurate our readings become. So that's why. So a one-off blood pressure can be wrong half the time. That's why you need multiple readings to get to the true blood pressure. Okay? And then the other thing the doctor will do is look at the patient. What is their risk for? We're trying to prevent heart disease and stroke. So what are their risk of heart disease and stroke? Looking at all the other factors. Do they already have heart damage? Do they have signs of hardening of the arteries? What damage do they have already from hypertension? And all of that information helps guide the doctor on whether or not that patient needs medical treatment. So in this case, in the case that we just talked about, Mary, with the blood pressure of 154/90, yes, I agree with all of you, she does need medical treatment. And the reason is her blood pressure is high and she has angina. Angina is partly caused by hypertension, so we know she's already got ongoing damage. She's somebody that definitely needs medical treatment. So when we see patients with very high blood pressure, so very high blood pressure means like a number like 160 or higher for the systolic blood pressure, greater than 100 for the diastolic blood pressure, those patients need treatment, medication treatment, regardless of what else is going on with them, because that's really high blood pressure. For the majority of people with hypertension, they fall into this range, just like Mary. Blood pressure between 140 and 160 for the top number, systolic, and 90 and 100 for the diastolic. Those are the patients where the doctor will weigh in, well, if I want to give them a pill every day, what signs of damage do they have? What are their risks of getting heart disease and stroke already? So do they have diabetes? So they put all of that together to decide whether or not that patient needs to be on medical treatment. So this is another case. This is a common case too. This is John. He's a 48-year-old teacher who was recently laid off from work. His blood pressure is the same as Mary's, 154/90. He doesn't exercise very much, but generally he's pretty healthy otherwise. So should this guy, the same blood pressure as Mary, get treated with medical treatment for hypertension? So how many of you would say he should get drug treatment? Okay, so a fair number of you. This guy actually does not need medical treatment at this stage because he's pretty healthy. Just have to go back. He's pretty healthy otherwise, and so he's the kind of patient that would do very well with lifestyle treatment rather than medication treatment. And he's the kind of guy that needs to get his blood pressure checked very regularly. Because if he crosses into too high of a level, then he needs treatment. If we start to see early signs of damage, then he's going to need treatment. So this is a guy who does not need treatment, medication treatment at this stage. So trying to determine what is my risk for having a stroke or a heart attack or any of these hypertension causing problems, there's this excellent website I really encourage you to write down. It's www.myhealthcheckup.com. And this is a sample of what they will ask you to put in your information, like your age, your cholesterol level, your blood pressure, your weight, your height, whether you smoke or not, that kind of information. And then they will do this calculation for you. So this will tell you what is your 10-year risk of having heart disease, your current risk of having heart disease, and also will have these numbers that you've entered right here. But importantly, this is a patient, a sample, a man who's 55 years old. But because of all of these problems that he has, his heart age, so the age of his heart, is actually closer to 63. So this will tell you how old your body is, how old your heart is relative to your age. And it'll also give you information just for you on what you should be targeting. So for this patient, it was reduce your total cholesterol by 25%, reduce your blood pressure to this amount, and it'll tell you how much you will lower your risk by if you do these things. So this is a free website that anybody can get. I encourage all of your friends to try to assess their own risk and even bring this to your doctor's office. So who can help me lower my blood pressure? And I'm going to talk about this. I'm going to talk about lifestyle, and Dr. Onrot's going to talk about medical therapy. So what I really tell my patients, a big intervention is you. So you can control your blood pressure. You can lower your blood pressure. But you can go to a hypertension specialist like Dr. Onrot, dietitians, your local pharmacist, a nurse, your doctor, even a psychologist. So everybody with high blood pressure should measure their blood pressure regularly. We've sort of talked about that. Increasing physical activity, controlling your weight, eating a healthy diet, cutting back on salt are all the things you can do. Limiting alcohol, becoming smoke-free, reducing your stress, and taking your medications as prescribed, all will help you control your blood pressure. And this is what I really always love telling patients. So an average pill that you will get prescribed by your doctor will lower your blood pressure close to this amount. So simply by cutting your salt intake, you can get the same effect as a blood pressure pill. You start to do more of these things, that's like taking more pills, but without actually taking pills. So I've had patients, I call my success stories, that have actually come off of pills or cut back on pills because they started doing these things. So if you don't like taking pills, this is my answer to you, that start doing these things. So lifestyle changes. So this probably reflects my house a little too much, but this is sort of the couch potato like a lot of us are unfortunately like. So we know that physical activity, not only does it lower your blood pressure, but it cuts your risk of heart disease, cuts your risk of stroke. It actually makes you feel better. So they've done lots of studies. People feel happier when they exercise. Helps you reduce your weight, reduce stress. So lots and lots of good things come out of exercise. And when I say exercise, what do I mean? So this is what's been shown in studies to reduce your blood pressure. So 30 to 60 minutes of exercise per day, and you do not have to do this all at once. But what I often hear about is, well, I went grocery shopping, that's got to be exercise. That's really not what counts. So your day-to-day, I go up and down the stairs all the time, that doesn't count. We want 30 to 60 minutes of dedicated exercise in total. So if you really can only get 10 or 15 minutes in, do it a couple times a day. If that's all you can handle. But about an hour most days of the week, so weekdays, okay? And these are just some helpful tips. Do some activities that you enjoy. If you enjoy going for walks, that's a great activity. Do it with some friends. Get your own lower your blood pressure club and go walking. Join a fitness class, but set some goals for yourself. Like, I'm going to start walking 10 minutes a day, and then next month I'm going to do 20 minutes a day, and so on and so forth. There's something new that came out, a new exercise that came out in the literature, and it's called isometric hand grip. I don't know if anybody's ever heard of it, but there's just newer studies, so I'm going to tell you about it right now. They found that people that, I'm going to put this down, so hand grip, so squeezing your hands or pushing up against a wall like this, just like this. I'm just applying pressure, squeezing my hand, and back and forth and back and forth, five times for 5 minutes a day, doing that maybe 15 minutes in total a day. Some early evidence is showing that has almost as much as walking or exercising for an hour. So this is isometric hand grip, and there's going to be more and more information coming out about that kind of new type of exercise.
How do you spell it?
It's called, isometric, 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 and it's hand grip, so hand grip. So walking, I won't go into this too much, but walking is a great way for weight loss, something easy that a lot of us can do. So control your weight, tough to do, but even a loss of 10 pounds is equivalent to 1 blood pressure pill. So some people may say, oh gee, I want to be 30 pounds lighter, but 10 pounds will be the same as taking a blood pressure pill. 10 pounds will cut your risk of diabetes. So that's really what we're talking about, a 10-pound weight loss. Of course, the more you lose, the better off you are, but 10 pounds is the kind of weight we're talking about. Salt, and this is sort of a big, I have to say it's a multi-billion-dollar industry that they put in everything that comes in a package, a ton of salt and a ton of sugar, and I think personally the reason is to make everybody addicted to that food because we all love salt. But salt is causing hypertension in many Canadians. There's a lot of people that are trying to lobby the government to try to reduce the amount of salt in our foods. But unfortunately, until that happens, you have to be sort of the on guard for how much sodium or salt is put in your foods. Salt is in anything that's packaged. That's really the nuts and bolts of it. So things that are fresh don't really have salt. But canned soup, like chicken noodle soup, all of that stuff, even cereal has salt in it, but really it's the canned goods, ketchup, potato chips, all of that stuff has tons of salt in it. We used to actually admit a patient to hospital. He'd go into heart failure every time he ate a bag of chips. So that has a lot of salt. So check your salt, check the food labels. This is an example of a food label. It's on pretty much almost everything that you can buy. Look for the salt and how much of it is your total daily salt intake. So you want to look for foods that provide less than 10% of your total daily salt intake. Alcohol. So it's not that no alcohol, sorry, let me make sure I say this correctly. So there are a lot of studies, like studies in France, that show drinking a glass of wine a day helps cut your risk of having heart disease. But when we say alcohol causes high blood pressure, it's drinking beyond what we call a low risk amount. And low risk amount for men is low risk is 2 or less drinks a day is okay. We're not saying to anybody who drinks 1 or none that you should start drinking this amount. But if you are drinking alcohol, it should be, for a man, should be less than 2 drinks a day and 14 drinks in a week. So if you drink it all on Saturday night, that's still not good. So, and for women, it's less than 9 drinks a week. Okay, and that's just standard drinks. So a beer is the same as a glass of wine. Smoke-free, there's lots of things you can do. Talk to your doctor about being smoke-free. Some people's hypertension is due to stress. Not everybody, and probably not the majority, but some people, stress causes hypertension. So in some people, if you do things to reduce your stress and you're noticing that your blood pressure is going down, then you are stress sensitive. Not everybody is, but you may be one of those people. No one can tell. The only way you can tell is if you try to reduce your stress and you notice, I am definitely reducing my stress and my blood pressure is going down. Okay, so now I'll let Dr. Onrot take over. He's going to talk about medications.
I want to talk about a bunch of things, not just medications, obviously. One thing that just struck me as Nadia was talking was I hadn't planned to talk about this, but I'd like to say a word about something that we're now finding out that is a big contributor to high blood pressure. Is anybody aware of a new, sort of a nouveau diagnosis, sleep disorders? Anybody heard of sleep disorders? Anybody know the name for that sleep disorder? Sleep apnea, obstructive sleep apnea. And obstructive sleep apnea actually occurs most often in people who are overweight. And we now know that people with sleep apnea have a very high incidence of high blood pressure, something like 70, 80%. They also have much higher incidence of cardiovascular disease and a lot of atrial fibrillation. It's kind of like the deadly triumvirate. We see a lot of people with sleep apnea, hypertension, and atrial fibrillation. So I just want to remind you of this, and If you have yourself or have spouses who snore, those people are at much higher risk for high blood pressure, and it can be treated with breathing machines, etc. So I just wanted to bring that to your attention. And also, if you have more, size 17 collar or greater, that correlates quite well to sleep apnea. So just give it a little check, or, you know. Can someone check this for me? Okay. So, do all people on medications for hypertension have their blood pressure under control? No. So most people with blood pressures over 160 will need more than one medication. Between 140 and 160 will need one medication or less, unless they use lifestyle changes, and that can reduce your medication by one pill or reduce your dosage. And one thing we've learned over the years is, and your doctor may suggest this to you, is that 2 pills in low dose may actually be better than 1 pill in high dose, and you may have less side effects. So don't freak out if your doctor wants to give you 2 pills instead of the 1 pill you've been taking for a long time, because that may even be a better thing. So pills need to be continued even when your blood pressure is controlled. But we do think that there are a large number of people that if they can institute lifestyle changes during the course of their drug therapy, it's worth a try to get them off drug therapy. And those people actually, so the people you can get off drug therapy are the ones who had one drug, it was all it took to control them in the first place. They had mild hypertension in the first place. They were female, don't ask me why. And they've instituted a number of lifestyle changes in the meantime. And so when you're consigned to drug therapy, it doesn't necessarily mean you need drug therapy for life. You may have the tendency to hypertension, and your blood pressure may have to be followed for the rest of your life, but you may get off drugs if you institute lifestyle therapies. Blood pressure pills need to be taken as directed. It's not something that you take when you feel like it, because you don't know what your blood pressure is. And if you're measuring it 20 times a day, believe me, it's going to be high from measuring it 20 times a day. The thing about hypertension, it's not really a disease, it's a risk factor. And you shouldn't let it take over your life, right? So, if people take a cholesterol pill, they take a cholesterol pill, but they don't think that they're going to drop dead if their cholesterol raises 5 points one day and lowers 5 points the next and raises 5 points. It's the same thing with blood pressure. It's a lifelong thing. And it really just needs to be followed. And whenever we do something, at least we have a way to check whether it worked or not. We just repeat the blood pressure. So in summary, it's silent, it causes disability, it can be prevented, and we can help you, and you can help yourselves to lower your blood pressure, which then the goal of lowering your blood pressure is not to have a better number, but to prevent you from having troubles later on in life, like strokes, heart attacks, etc. Maybe not today. And what you can do is know your numbers, know your targets, measure your blood pressure at home, make your lifestyle choices, and take pills. So I want to give you a case. I saw the case yesterday. This lady I saw yesterday in my clinic. She had 10 years of high blood pressure, and in the fall when I first saw her, she was running 120 to 140 at home, 60 to 70 diastolic. And she was on 3 pills to obtain that. And she felt well, and she really had no other risk factors or problems. And when I saw her, she was 170 over 90. What's that called? White coat hypertension, or office hypertension. I did some minor adjustments in her medications, and they actually worked. And her blood pressure was much better at home, 115 over 65. But now she wasn't feeling as well. So when she was taking her pressure, it was 115 over 65, but it's conceivable that at other times it was 100 over 50, and she was getting dizzy. And when I saw her in my clinic, she was still not controlled to what we call the goal pressure of systolic 140. So how many of you would give her more medications to get her blood pressure to that goal? How many? Excellent. I mean, You guys have learned already that we treat the patient, not the pressure. If I give this woman more medication, she's going to get dizzier. And she's going to fall. And then she's going to end up in hospital. From a nice healthy lifestyle, taking blood pressure medication, I'm going to cause her complications that'll, make her sick. So I want to talk about the concept of white coat and masked hypertension. So this is a complicated slide, but across here is your office blood pressure, like 120, 130, 140. And up here is the blood pressure you get at home, 135, 140, 150, etc. And you can see that patients who in the office have a high pressure, and when they measure it at home, they also have a high pressure. We call that true hypertension. It probably shouldn't be called that. It probably should just be called sustained hypertension. No matter where you measure it, it's high. And the patients who are always normal are not the people we're talking about today. But the white coat hypertension is the patients who, when they measure it at home, like our patient, it's normal, but it's high in the office. And then there's this concept of masked hypertension, which is somewhat rare, but maybe about 10% of treated hypertension patients. And I've seen this quite often because of my practice, where they're only high at home. And they come into your office and you go, oh, you're 130 over 80, get out of my life. You don't need treatment. And then they come in with their pressures in their 150, 160, 170 over 100 at home. Those people do way worse than these people, believe it or not. And it makes sense because you spend 1/100,000th of your life in a doctor's office and you spend the rest of the time not in a doctor's office. And your true blood pressure risk is cumulative based on your blood pressures over a lifetime, not just in doctor's offices. So that's, does everybody get the concept of white coat hypertension and masked hypertension?
Why is it low at the doctor's office?
Nobody knows. There's some people are more like they might be totally stressed at home, or they might be the kind of people that respond to stress, and they might feel much more comfortable in the setting. It might be the only time they get to relax during the day is when they wait 5 minutes to have their blood pressure taken. So it's not a big part of the population, but we don't like to miss those people.
So this is assuming that they're taking the blood pressure correctly.
Yes. And you go through that, and you actually, how do you know they're taking their blood pressure correctly? How would you know? Anybody? Ask them to bring the device to the office and watch them take it. And then you'll know. And also, I do this, and I say, take your blood pressure, don't tell me what it is. And then I take their blood pressure, and then I compare, and then I tell them to take their pressure again, and I do it again, so we have like multiple comparisons, and then I can tell whether their machine's accurate or not as well. So those are important points. And the point I wanted to make, and I think I mentioned it to you, is white coat hypertension isn't much worse than normotension for causing strokes and heart attacks. But the people who have masked hypertension are very important to know about because of this. So, and sometimes and that's why it's important in our hypertensive patients now that we get them to measure their pressures at home. And it's fantastic for us and it's fantastic for them. And it really engages the patient in the process as well. And they are their own doctor to a degree. But don't be screwing around with your medications without telling me. And also, we know that people's pressures in general are lower at home. So a home pressure of 135 over 85 is about the same as an office pressure of 140 over 90. And if you're hooked up and it's measured for 24 hours, and we know it's lower when you go to sleep, if you have an average pressure of 130 over 80 or above on the ambulatory automated recorders, it's like a computer, like you wear it. I don't know if you're familiar with Holter monitors. So you wear a box, and your cuff automatically blows up at various times during the day, and it's downloaded into the computer, then downloaded into the box, then downloaded into the computer, and we can analyze your 24-hour blood pressure patterns. And it's very helpful for us. So, and this is the new thing, is getting patients to measure their blood pressures, getting ambulatory readings. We're doing it much more. It's becoming much more easily obtainable. So who do we do it? Well, I pretty much tell everybody to do their pressures at home, unless if they're a really nervous person and they get really uptight, I tell them don't measure your pressure at home. But if you know, patients who I think they're not taking their medication, or I think they're white coat or masked, those patients especially should be checked. And the ones that also, of course, should be checked with the automated recording, the computerized recordings, are the ones where their home pressures do not compute with your office pressures. So the automated becomes the arbiter and your main decision maker. When should I be worried? Stop worrying, okay? It doesn't do anybody any good. But when should I call the doctor? Let's see. So this is a tale of two patients. Patient number 1 has a pressure of 190 over 110, comes in with headache, blurred vision. He's already on 3 drugs. He comes in sorry, he doesn't come in. He has a pressure of 190 over 110 at home. Should he be calling me? Yes. Yeah. Why? Headache and blue. He has symptoms. The second patient is feeling fine on 2 drugs. Checked his pressure at the pharmacy one day because he was in there buying cough syrup. And his pressure was 220 over 120. Should he call me? Yes, but he doesn't need to come in tomorrow. This patient needs to come in yesterday. So this patient calls me up and I say, come in right now, go to Emerge, go somewhere, get checked up, because this is serious. This is not serious. And that's the point. We're treating patients, not pressures. The higher pressure doesn't freak me out nearly as much as the patient who's sick with a lower pressure. So we're treating patients. And it's like Nadia said, if you've got a patient who's 150 over 90 and is completely healthy, no other risk factors, versus a patient who's 150 over 90 who's diabetic and has high cholesterol and already has angina, exact same pressure, 2 different beasts to treat, okay? And that's the whole point that we want to make. We're treating patients, not pressures. And when you're home, you shouldn't be obsessed about your pressure going from 150 to 160 back to 145. That's what blood pressure does. It's not a football game. So when it's 160, it's not like you're losing, and 140 you're winning, because it's going to be 160 the next day. It's a football season, not a game. A football career. It's not a disease of the right arm. Okay, so should you be worried? Less than 130 over 86, get out of my life. 130 to 179, 85 to 109, you're okay. You just need to go back at your regular scheduled visit. Once you're at that level, you should schedule an appointment with your doctor, and he should see you as soon as he can. And at this stage, you need to get it right. You need to get seen right away. So you should call up and get seen right away. Okay?
What about if your systolic is, say, 150, or basically double of the diastolic? Say 150 over 75.
Less than...
It always seems to be a ratio of 2 to 1.
You're talking about the pulse pressure, the difference between systolic and diastolic, and
On the blood pressure, yeah.
very complicated. Very complicated. In brief, systolic pressure is more dangerous than diastolic pressure. It predicts events more strongly than diastolic pressure. However, for any given systolic pressure, you're actually may be at more risk if your diastolic is lower, so you have a wider pulse pressure, because it may be that the arteries might be being pounded by the difference between 75 and 150 is less pounding than the difference between 90 and 150. But that's a very simplistic way to look at it. But somebody 150 over 75, that's fine. That's completely great. Obviously you'd want the 150 to be 140, but it would depend on the overall patient status. And many's the patient that comes to my office and is 150 over 75 and gets sent away with some reassurance and a pat on the back.
I'm taking what they call the water pill, which is Coruscant, I think. And pressure goes down. But then everyone else says, drink lots of water. And I drink a lot of water.
Well, you know what? Calling it a water pill is a misnomer. They're not really they're really natriuretics, which is salt-losing pills, not diuretics, which is water-losing. So, you know, when you think about it, the other thing about it is the diuretics, we're not exactly sure how they work, but we know damn well that people aren't completely losing water and salt all the time on diuretics. Some of you have probably been on diuretics for years, and I don't see you being prunes out there. So the point is that it's kind of a misnomer, and you shouldn't think of it in terms of just think of a diuretic as another blood pressure lowering pill, not necessarily as a water losing pill. And I'll just if you have questions about your cells and the drugs you're on and everything like that, we're delighted to answer them, and we really want to leave time to answer them. So feel free to save them for the end, and we'll. That's.
No, the end isn't here yet to answer questions.
Yeah. Oh, no, well, no. I want to answer questions as we go along. But if you have questions actually about should I be taking this or should I be changing or why should I do this, we're happy to take a shot. So here's what I do. This is how I teach doctors. So I say to doctors, we're treating patients, not pressures. So what I'm a tailor. I'm a custom tailor. You go and get your blood pressure treated by me. I'm going to custom design a suit of clothes for you. First, I have to take your measurements, like any good tailor would. So it's custom tailoring, not off the rack. And those measurements are what we talked about. And all of these things affect what we're going to decide to use in you. Your age, whether you're male or female, black, white, green, yellow, what your lifestyle actually is, your overall risk assessment. We're going to be way more aggressive with diabetics, smokers, because they're the ones that are at the risk, that we can reduce the risk. If we have the same percent reduction in people that have a high risk, we'll get a more absolute reduction. We'll help more people that are at risk. Then we choose the cloth, cut the cloth, try it on. If it works, fine. If not, come back. We got a money-back guarantee. We'll get you a different suit of clothes. And that's basically what we do. And how do we come up with these educated guesses? We base them on the patient demographics and what else is going on in the patient. So I want to talk about twofers. How many of you know what a twofer is? A twofer, 2 for 1. So 2 for Tuesday, you go to the movies with your friend and your friend gets in free. All right? We're always looking for a deal. As doctors, we're always looking for a deal too. If I can find a drug that treats high blood pressure and something else that the patient has, that's a twofer. So we're looking for twofers. Some examples of twofers might be males who have prostate problems. There's drugs that treat high blood pressure and prostate. Some people who have heart failure, well, they want to be on the water pills. There's drugs, the prills, which are also known as ACE inhibitors, and the sartans, which are known as angiotensin receptor blockers, beta blockers. They all have indications for patients with heart failure, but they will also lower your blood pressure. So it's a twofer. Patients with angina, the drugs that treat angina and hypertension. And diabetes, there's drugs that work in diabetics to actually lower cardiovascular disease, regardless of their blood pressure lowering effects. So we're always looking for twofers. That's what we're up to when we're taking these histories and asking you thousands of questions that you never thought we'd ask you, but you're only too happy to tell us the answers to. So those were the kind of the cases I wanted to bring to your attention and the kinds of things I wanted to talk about. Did you want to do this little quiz? I don't know. We have plenty of time for questions. Blood pressure measures the amount of pressure in your arteries. Blood pressure greater than 140/90 is too high. You can tell if your blood pressure is too high by the way that you feel. Take one elevated reading means you have high blood pressure. Hypertension is a major risk factor for stroke and dementia. having a healthy weight, regular exercise, eating a healthy diet, restricting alcohol intake, and reducing salt intake can help treat high blood pressure? Oh, come on. It's false. It's patently false. Oh, got one wrong. Smoking increases blood pressure. People who do not have high blood pressure should have their blood pressure checked every 3 to 4 years. How many years? If you're taking pills for high blood pressure, you'll need to stay on them the rest of your life. Wrong. This answer is wrong as well. You will need to, you'll have high, it's not right. We try and get people off high blood pressure pills. It was a trick question, and I'll be writing my congressman about this one. And if you're older than 65 and your blood pressure is elevated above your target, despite your lifestyle, should you be considered for medication? Sure. We treat older people pretty much the same way we treat younger people, with the caveat that we treat healthy older people like we treat younger people. Very sick older people, we do not treat like we treat younger people because they're very sick. We treat them like we treat very sick younger people, actually. So we now know that treating older people with drugs actually can prevent heart attacks, prevent strokes, and it's worthwhile to treat, especially healthy elderly patients. With hypertension, it's worthwhile to treat them. So that's it. That's all I wanted to talk about, and we'd love to handle your questions, and you can ask about yourselves or whatever you want.